So welcome everyone to the Network for Community Engaged Primary Care Research for Morehouse School of Medicine Learning Series. So today we have two wonderful presenters, Dr. Anita Misra-Hebert and Dr. Mason French. The title of their presentation is Evaluating New Care Models in Primary Care Settings, Types of Data You Can Collect. So before we get started, I just want to share a few housekeeping rules. If you have any questions, please drop them in the chat box. We will address all questions towards the end. Also, we will drop an evaluation link in the chat box. So please open the link when time permits to fill out the evaluation. Our first presenter is Dr. Anita Misra-Hebert. She is the director of the Healthcare Delivery and Implementation Science Center at the Cleveland Clinic. She is also a practicing internal medicine physician, a clinician investigator, and associate professor of medicine at the Cleveland Clinic Lerner College of Medicine. As of March of 2023, Dr. Misra-Hebert is project co-lead at the Cleveland Clinic for the new PCORI Health Systems Implementation Initiative, which is a 7-year program collaboration with PCORI to focus on implementation of research evidence into routine practice in the health system. Dr. Misra-Hebert is committed to advancing healthcare delivery and implementation science across the Cleveland Clinic enterprise and to promoting rigorous study of both implementation of novel care delivery models and of dissemination of research evidence into routine practice. Our second presenter is Dr. Mason French. She is a senior research scientist in the public health department at NORC at the University of Chicago. She has engaged in evaluations of local, state, and national initiatives and is attuned to measuring processes and outcomes from individual, organizational, and systemic perspectives using participatory and equitable evaluation approaches. At NORC, she has led the qualitative components of mixed methods evaluation of large-scale, multi-year demonstration projects like the Centers for Medicare and Medicaid Innovations Healthcare Innovation Award and the Next Generation ACO model. Currently, Dr. French supports the evaluation of the Network for Community Engaged Primary Care Research with Morehouse School of Medicine. So without further ado, I will turn it over to our first presenter, Dr. Anita Misra-Hebert.
Thank you so much. We are just thrilled to be able to present to you today. Our focus today is really going to be to talk to you about different concepts that you can use when you think about evaluating new care models in your own primary care settings, and specifically on the types of data that you can collect. And I just want to mention that we are going to be talking about kind of multi-health system or health system level implementation of care delivery models today. But these concepts that we will be discussing can really apply to one practice and even smaller level changes that you might be thinking about implementing and the types of data you may collect in those situations. So I just want to mention that because we are really hoping for some discussion towards the end of our presentation today. So I want to start by saying that evaluating new care delivery models may not be straightforward. And we, just as in this cartoon, a lot of times we implement new models, we look at the outcomes. We look at clinical outcomes, adoption outcomes, and we don't really think about the context of where we're implementing. Like, what is that miracle that occurs in the middle there? How are we actually implementing these new concepts or this evidence into practice? And what could we have learned from what happened in those particular clinic settings or health system settings where we implemented that could help us to implement more effectively, potentially in the future, if things didn't turn out exactly the way we planned it. So this is all about trying to understand that miracle that occurs when we start implementing. So overall, implementation science methods can really help us to frame evaluation of care delivery models and implementation. So what we're trying to do when we implement new models into care delivery is bringing evidence and bringing it into routine care delivery. So for example, the COVID vaccine, we know that it was effective and we want to implement it into our care delivery settings. So then at that point, we evaluate outcomes or clinical outcomes, and we wonder again, what happened in particular settings. Maybe this really worked well in clinic A or in hospital A and didn't work as well in clinic B. So what we have to remember is that most of the time when we're implementing any type of new change into practice, that there is going to be some adaptation. There is going to be some tailoring, just according to what is necessary in that particular setting. And so the part about what type of data that you can collect that we're going to focus on today is understanding what was adapted, how close is it to what we had initially intended to implement, and what can we learn from that? What does that tailoring help us to understand about this big center here, the context of where we're implementing? So context is a big word when we're thinking about specific care settings, and then thinking about different levels of where we might collect data and evaluate the context. Are we going to collect it at the health system level? Are we going to collect it at the practice site level or at the individual provider level? Maybe it's a provider-facing intervention that we really need to understand how providers are acting and why they may want to uptake an intervention versus not. Or are we collecting data on the patient level? Individual patients may uptake interventions differently. So just kind of thinking about the big picture and where we want to, which level of evaluation we want to focus on when we're trying to understand implementation, collect data. So this is the Consolidated Framework for Implementation Research, which may be familiar to many on the call or may not be. This is a commonly used framework when we're trying to study implementation and figure out where we want to collect data. The important part of this model is really thinking about these 5 domains, the actual intervention or innovation that we are trying to evaluate or implement. Who are the individuals involved in that implementation effort? What is this whole inner setting? So potentially like the clinic setting or hospital setting. What is the outer setting? Are there kind of external demands that are forcing us to implement in particular ways? And what is the actual process of implementation? So I want to focus a little bit on this because this is an incredibly helpful framework to utilize in any type of data collection for implementation or care delivery model implementation. So when we think about the intervention or the specific care model that you're trying to implement, that model is going to have some core components. So there are going to be particular things about what you're trying to implement that if you don't follow those particular things, that it's really not that model anymore. But then there is going to be something called an adaptable periphery, which is where, as on the last slide, I mentioned about adaptations that could be made based on particular context, that it's okay to make a few adaptations, but still call it that same model or that same tool. So for example, we're going to implement a tool to help with diabetes care, and it's going to be implemented in the electronic medical record. There will be core components of that tool that if you implement that tool, you're going to have those components for it to be called the tool. But then there may be parts where you find that particular clinics use one part of the tool, but not the other. And that's maybe the adaptable periphery. So say you implement using that same example, that tool in the electronic medical record, there will be individuals involved. So what data do you want to collect about the individuals? Is there a provider champion that really thinks that everybody should be using that tool in that practice? And so that practice does really well in implementing this tool. What is the inner setting like? What is that practice setting like? What resources are available? In general, are physician champions or nurse champions within a practice really recognized as people that we want to follow in terms of what they're recommending? So what's going on in that inner setting? You can collect data about that. What's the outer setting like? We have quality metrics. So is there a particular quality metric that we're trying to meet, and that's really promoting adoption of this new tool to help with diabetes care? So then once we implement and we kind of have this process of implementation, which is another piece that you can evaluate, what is really required to implement? What systems are required? What resources within the setting are required to even have this happen? And then once we're completed implementing, we kind of see which core components were maintained and which parts of the adaptable periphery do we need to really understand to understand the context of that implementation. So again, it's a great framework to use for any type of effort. So I have alluded to the different types of data collection and how we might capture context. A lot of what we're going to talk to you about today is the fact that we can use qualitative and quantitative data to collect within your individual settings to capture specific implementation outcomes. So the ones I've listed here are from a paper published by Noah Proctor many, many years ago, but are still extremely relevant. And you may add particular implementation outcomes to this list, but these are still kind of the major ones that we should focus on when we think about trying to understand that context of implementation. Things like acceptability, feasibility, appropriateness. Those are incredibly important. I mean, if you're going to implement a new care model or a new tool, is it going to be acceptable to the people that have to use it? Is it feasible? Does it make sense? Is it appropriate for you to do this in this particular practice setting? Those types of outcomes can be collected with qualitative data collection, which you're going to hear a lot about from my colleague, Dr. Freij, very soon. Other outcomes, including adoption, such as what % of providers are using this particular model, this particular tool. That is more of a quantitative outcome. Fidelity, again, we talked about these core components and the adaptable periphery. Fidelity is about how much do you maintain fidelity to these core components and the model as it was supposed to be implemented, and then what percentage has been really adapted. Cost, what is the cost of implementing a model? What is the human cost, and what is the opportunity cost? What does it take time away from that you were otherwise doing now that you're focused on implementing this new model? How sustainable is it? Does the new model only last for the time that somebody has a grant to fund this to happen, and then that's it? Or is it sustained a lot longer after the evaluators have left? And then finally, reach and penetration. Thinking about it at the health system or community level, how far is the reach? What % of practices have really adopted this intervention that you're implementing or this new care model? How much has it penetrated into the community, even into other health systems? So those are the types of concepts we want to really be thinking about and allow us to have a framework for where we want to collect our data. So I'm going to now turn this over to my colleague, Dr. Freij, and I can continue sharing the screen, Dr. Freij, and you can tell me.
I appreciate it. Good afternoon, everyone. Thank you so much for inviting me to present today. And so I will be going into some details about the basics of qualitative research, and then I will tie it back to doing mixed methods research related to healthcare system implementation of interventions, and even the CFR, as we came to know it, the Consolidated Framework for Implementation Research, and how that works. So if anyone has any questions, feel free to ask me, and I can stop.
We're gonna go to that thing.
But you also may want to mute if you don't have any questions. So basically qualitative research designs.
We were gonna have to take 2 buses.
Okay, thank you. So qualitative research designs are particularly good at understanding phenomena in their context. So uncovering links between concepts, behaviors, generating and refining theory. So, and by phenomena, we mean behaviors, programs, policies, interventions or treatments, systems. They could be health, education, social service, or health conditions, but things that are generally complex, not binary, like yes, no, so forth, so that you can really try to understand really the complexity. Qualitative designs are valuable when there are components that are maybe not easily measured or require hearing from populations, particularly those that may not be given a voice in research processes are often overlooked. So you may not even have the measures to structure close-ended questions where you know the outcomes of and that you want to check. Also, qualitative research generally involves communication. It's really all generated by words and talking and dialogue. So it allows researchers to really build trust and answer participant questions about the research, and also allows participants to kind of choose their own words and express themselves directly. So it can really elevate the voices of those you speak with. in a research kind of context. Would you mind going to the next slide, Dr. Misra-Hebert? Thank you. So I like this list of questions because it's like, well, what do I ask people? So common qualitative health research questions include, and these kind of get at both the processes of implementing something or even the outcomes, but like who's involved in X phenomena and why? What are their perspectives? How was something implemented and what were facilitators and barriers to its implementation? To what extent does implementation change over time? One of the things that, my background is actually in anthropology, and early anthropologists had this idea when they went to look at populations that they were kind of fixed, and static. And this was the culture. And over time, the field grew, obviously, and we realized that everything changes over time, as we all know from our own aging processes. So it is important to kind of even look at implementation, how that changes over time. And that's a very common qualitative question. To what extent do participants' behaviors change? And this kind of gets at like more outcomes. What is the context in which it is taking place and how does it take shape? And this context could be anything from local or regional politics to historical conflicts or historical events, including maybe even, if it's a particular clinic, the in-migration, out-migration of different populations that affect the characteristics of the population, or a really big context people often hear about in healthcare settings is turnover. Are they all new staff and people need to start over? So these are kind of really important things to keep in mind. Characteristics is a common question. And to what extent some characteristic relates to or influences something else. This is a question you can ask people and get their thoughts, because our brains are very good computers and put together analyses that is complex. And what are possible reasons why something is happening? Again, humans tend to try to analyze and think through things as well. So you can just ask people. So there are multiple qualitative methods that can help you answer your research questions. And there are different values, let's say, from one method over another. So a common one people know is interviews. So it's a good way to, often one-on-one or one with two people, to solicit experiences, opinions, feelings. It's also good for addressing sensitive topics where people might be embarrassed to talk in front of other people, say about their living conditions or about how they can or can't manage an illness, let's say. And the participants in the healthcare environment setting could be professionals, experts, community members, particularly those who may be overlooked or vulnerable. Focus groups are larger group interviews. They were commonly used in marketing research, but we use them very often in healthcare research as well. So it's good for, in a way, identifying group norms, because one person can say something and others can say, oh, I agree or I disagree, and this is why. It's good for eliciting groups of opinion, so you get a certain efficiency, let's say, instead of having to do 9 interviews, you can get 9 people in one group. It's good for discovering variety within a range in a population as well. And typically, you can arrange them in different ways. You can have a variety of types of people in a group, or you can kind of try to construct groups around a similar type of people, like all professionals or all community members. You just kind of have to think about the aims of your research. And observation, this is a very common qualitative technique, which is participant observation. So you might sit in a site and observe, let's say, a clinical flow or intake, or how, let's say, an example from my experience is like observing patients who are limited English proficient, and how do they communicate, get services in an environment? Are they aware of language assistance or not? It also may help identify behaviors that individuals may not be consciously aware of, so you can observe and take notes. And there are certain, I've been kind of saying as I go, certain strengths for each of these methods, but they're also listed here, and I believe we'll share the slides afterwards. So next slide. So qualitative research, like the practice of medicine, follows certain ethics, including respecting for persons and their autonomy as research participants, commitment to minimizing risks, justice, and commitment to ensuring fair distribution of risks and benefits from the research. So really informing people and letting them know that they're doing research. And this kind of even applies to the observations. There's in an observation context, you generally would want people in that context to understand that you are observing and making notes for that. And these principles are particularly important to uphold when working with people in communities that are disadvantaged and yet are commonly the subject of research. Next slide. Similarly, in terms of both ethically, but also in terms of being able to generate accurate and reliable data, is you want to be culturally responsive and equitable in terms of the data collection. So you want to think about the study populations in the communities and understanding their context, how different subpopulations may differ. You want to make sure participants are comfortable being involved in studies, ensure they have benefits from the study, and you also want to check your own assumptions about the populations you're investigating, and also even your evaluation questions. So being aware of your own culture, biases, and stereotypes may help you interpreting information that you're gathering. And that's also very important. And then I just have a couple good resources listed at the bottom on the slide. One that I like a lot, and my colleagues and I discussed a lot when it came out, was this guidebook called Why Am I Always Being Researched? It's by Chicago Beyond Equity series, and it's by a group that I think does mostly youth engagement, but really pushes this mantra of like not for us without us, that you can't just do research in populations without really engaging them. And then I have some other references too. So this is sort of some background in terms of qualitative and my perspective on qualitative and its powers and the strengths of it in terms of doing healthcare research, even in terms of doing implementation research. Next slide. So I want to return to an example of healthcare research that uses this consolidated implementation framework. Between 2012 and 2016, the Centers for Medicaid and Medicare Innovation, which is part of CMS, Centers for Medicaid and Medicare Services, they funded multiple interventions aimed at improving diabetes outcomes. In fact, they funded multiple interventions across the country on a whole range of health issues and behavioral health issues. It was actually $1 billion worth of funding awards to organizations to implement new ideas to deliver better healthcare and improve population health, while their mantra is while maintaining or lowering costs to people enrolled in Medicaid and Medicare. I mean, potentially some of your organizations were part of these awards as well. So 3 of them actually related to diabetes. One of them was First Vitals, and this was a telemonitoring program. It was staffed by lay and clinical staff, and the other one was Jocelyn's On the Road program. And these were implemented in different health centers, but they were community-based diabetes education screening. They were implemented in communities that were associated with different health centers. But they're community-based diabetes education screening for individuals who have diabetes or at risk of developing diabetes. And then the Southeastern Diabetes Initiative, which had 3 interventions focused on different populations at varying levels of risk. And NORC, where I work, we were the evaluation contractors for these. So we were doing evaluation or implementation science research on how all these different programs were being implemented across the country. So if you could go on to the next slide. So in terms of qualitative data, just for analyzing these 3 diabetes programs, we did a really large number of interviews. We did 111 interviews, and we interviewed a variety of staff in 2 site visits. So program staff, supervisors, leaders, partners, and partners could be community-based partners or payers. And we did 2 rounds of site visits. This was still in the days where you went places. So I had colleagues, and me and colleagues went all over the country to look at implementation. So we also did focus groups and phone interviews with 92 program participants, so people who were meant to be benefiting from these programs. And we reviewed awardee quarterly reports. So there was some program documentation too that we read, and then we summarized as well. So the next slide. So then, when doing qualitative data research, because you just get lots of data that are all words and they're reports, and you have to sort through it, but there is a way with qualitative data to use a rigorous and systematic approach to analyzing it. You can combine data from multiple sources and perspectives, like interviews, focus groups, observations. You do identify patterns and build explanations that address the research questions. You can use triangulation, so these different data sources, you're like, what did this person say compared to that person, to really try to arrive at a kind of common understanding of implementation. And you basically also try to document and validate findings across a research team. The next slide. I believe this is my last slide on the qualitative. So for the diabetes programs, they were very diverse in nature. So we did look at the consolidated framework for implementation research to try to frame our findings across the different awards under 3 main themes. So we did look at adaptability, we looked at the use of technology, we also looked at partnerships. So we really analyzed the data across these themes. And then on the slide, I have some of the actual findings if you're interested. In terms of adaptability, the multi-site programs, they required a certain amount of flexibility so that sites could tailor things. And the use of technology was challenging, but that, personal relationships and advanced planning and strategic partners helped alleviate those challenges. And in terms of partnerships, that was very critical for implementation, really, because the partners were knowledgeable about the local populations, and they helped tailor interventions to the patients. I believe that's the last slide on the qual. Do you want to go to the next slide? Yeah, so this is back to Dr. Misra-Hebert. So thank you so much. And I'll be here for other questions.
Thank you, Dr. Freij. I really appreciated that in-depth discussion of qualitative research methods. And I can tell you that as a physician researcher, I have such a huge amount of respect for qualitative researchers, and that's just the whole methodology, because I think that even in my own research, I have attempted to use qualitative data, perhaps not as in-depth as what you have done, Dr. Freij, but I think that the value is just incredibly important when trying to understand implementation and outcomes related to implementation. So I'm going to talk about mixed methods, which is where we use quantitative and qualitative data combined. And I'll give you a couple of study examples that I have been involved with at my own organization that have used mixed methods. So just a brief overview. There are, in general, these 4 types of mixed method study designs. There are definitely subcategories of these, but just to give a general overview, that the mixed method study designs really differ based upon when you collect the quantitative and qualitative data. So the convergent mixed methods design is where you collect quantitative data and qualitative data separately and then kind of bring them together at the time of analysis to try to make sense of the data, maybe trying to understand each of the data elements together by looking at both. Explanatory sequential design really is collecting the quantitative data first and then saying, well, maybe I don't understand what is exactly going on with the quantitative outcomes that I'm seeing. There's a lot of variation here. I want to do some qualitative data collection to try to understand this better. And so you would do the quantitative first and then maybe do things like focus groups or observations or interviews to maybe make more sense of that quantitative data. Exploratory sequential is where you collect the qualitative data first, and it might be about a phenomenon that you don't understand very well. So it might be something new, a new care delivery model that maybe isn't resonating with everybody, and so you kind of want to go in and do interviews or observations and understand qualitatively what the local context might be or within a particular clinic, and then after that, you might then say, well, I understand these are the major themes that are coming up in my qualitative data collection. So now I want to create a survey that I send to all practices because now I understand what I want to ask and what the issues are based on my qualitative work. And then the fully integrated design is really where you're collecting quantitative and qualitative data at each stage. So potentially you're doing an implementation effort, you're collecting the quantitative implementation outcomes such as adoption, or fidelity, but then you also want to find out about acceptability and feasibility, and you're collecting these at the same time. So again, that's just kind of a general overview. A lot more detail is available on those for those who are interested. So now I'm going to talk to you about an example study, the first example study. And this I'm really choosing to talk to you about because it really emphasizes just triangulating this data from not only different qualitative sources, but also qualitative and quantitative sources together. And this is a project where we studied primary care practices within our Cleveland Clinic health system. So just a little bit of background on that. We really felt that probably successful implementation of new care models within a health system is likely dependent on these contextual factors at the individual practice sites. And that new care delivery models may be associated with quality of care and patient and provider experience. And so those were kind of what we thought about when we designed this study. So we designed a convergent mixed method study. So again, that's the quantitative and qualitative data collection being done separately and then brought together later. We focused on factors that were associated with successful implementation of two new team-based care delivery models within our primary care practices at Cleveland Clinic. So we did a comparative case study of 9 primary care practices. And at these practices, 1 of 2 physician medical assistant team-based models had been implemented at the time. And these models consisted of, the first model was 1 physician working with 2 medical assistants, where the medical assistants could help scribe clinic notes and also be available to help with additional work that needed to be done while the provider was seeing patients. The second model, which was also a medical assistant physician model, was a model where there were 4 medical assistants assigned to 3 physicians, and it was more of having an extra medical assistant to help with additional tasks within the clinic. And all of this was, of course, to try to increase the efficiency of primary care practice. So we collected the quantitative and qualitative data. So our quantitative data sources included a survey that actually more than 1 survey that was sent to primary care employees, baseline and 2 follow-up time points. We used something called the adaptive reserve measure, which is a 3-item measure that really kind of gets at how flexible or how adaptive a practice is to implementing something new. And then we also submitted administered the Maslow burnout inventory, knowing that burnout was probably going to be related in some way, or hypothesizing that burnout would be related in some way to the uptake of these new models. We also then looked at routinely collected ACO quality metrics. And this was done a few years ago, so that was from 2016. We used measures specifically for preventive care and diabetes and hypertension control. And then we also had a measure of patient comorbidity. So we looked at the mean patient panel Charlson comorbidity score for all of the providers, where we were looking at the uptake of these new models, just to make sure that we did not compare practices where comorbidity was much higher. As you know, that can be an issue when you're trying to make or have conclusions about why a model was implemented well in one place and not as well in another. Qualitative data collection, we actually did do field observations at all 9 sites. I mean, I was personally involved in that with my nurse research assistant. We did 4-hour observations, and then we went back and did follow-up observations. And during these observations, we also did informal interviews of clinic staff, including providers, medical assistants, and any of the clinic staff that were willing to talk to us. We used field notes and observation templates, and that's how we kind of added the rigor to doing these observations. And then we did 75 formal interviews that were audio recorded, and our data there were interview transcripts. And you can see the number of physicians, MAs, and licensed practical nurses, nurse care coordinators, and patients that we interviewed about, or at these practices about these care models. And then we also had another source of data where I was running a primary care stakeholder panel for many years at Cleveland Clinic, where we had employees and patients. So then we brought our data to this panel and got feedback from the panel about what they thought about the data that we were collecting and our initial impressions. So using those data sources, I just want to give you a brief overview of the results. We were actually able to come up with practice groupings based on our qualitative data. So this is kind of the data we collected through observations, interviews. We had themes that came out of that data, and using those themes, we actually were able to group practices as lower uptake of these new models, partial uptake, and higher uptake. And so the things that we really found were important, which you may not be surprised about, is that practices with flexible workflow and team roles, if they had a lot of flexibility in their ability to adapt to new team roles, they were going to be a high uptake practice. Those with lower flexibility were a lower uptake. And then this overall concept of responsiveness to change, which came across in interviews. If you had a high level of responsiveness, you were going to be a high uptake practice. And again, we did not have these kind of set out in our minds about what we were going to find, but this really came out of our qualitative data. The other 2 concepts about local leadership and stable staffing were incredibly important too, kind of as mediators. So we had these 2 big concepts of flexible workflow and roles, and then responsiveness to change. But we knew that these lower uptake practices were lacking in either strong local leadership or stable staffing. And the higher uptake just had both, and partial uptake had one or the other. So then what we did is we had these practice groupings based on our qualitative data, and then we merged the qualitative and quantitative data. So you can see here our theme. We talked about this responsiveness to change and flexible workflow. The higher uptake practices scoring really high on those 2 qualitative themes. There were other qualitative themes that didn't seem to really differ between or among the practices, including value of relationships, practice challenges, concerns about the future of primary care. They were pretty much similar among all the practices we looked at. Our adaptive reserve, interestingly, did not differ in terms of their responses between the lower, partial, or high uptake practices. And the Maslach inventory questions, the domains of emotional exhaustion, depersonalization, personal accomplishment, actually did not differ too much that in terms of the uptake level. So we thought that we were going to find a relationship with burnout and with adaptive reserve in terms of the uptake, but really there wasn't as much of a relationship as we had thought. What we did find, however, on the performance on these ACO quality metrics, influenza vaccination, pneumococcal vaccination, colorectal cancer screening, mammography, and diabetes control, all were better in these higher uptake practices, which was really an interesting finding, and we didn't go in expecting this. Interestingly, the hypertension control seemed to be best in the partial uptake practices, and I'm not completely sure why, but that is what our data showed us. So it was incredibly valuable to do this mixed method study to kind of understand that maybe there was a relationship between what would have a practice perform well on quality metrics and higher uptake of these new care delivery models. And again, opens up to a lot more exploration of the practices that maybe were the lower uptake practices to try to go in and examine the context a bit more. So again, that was one example. My second example is a study where we really felt like we improved the understanding of our quantitative data with our qualitative data sources, which would then help us to inform future interventions. So this particular study looked at a post-discharge home visit program that was implemented in all of our primary care, or actually for patients that were cared for in our primary care practices, but who had been hospitalized. So a little bit of background on that. So our goal was to assess the effect on healthcare utilization and mortality for patients who are at high risk for readmission after hospitalization, and look at those who participated in a post-discharge home visit program compared to similar patients. And we also wanted to examine provider and patient experience regarding this home visit program participation. So this initial intervention actually started in May of 2018, and then was adapted in October of 2018. And so we really had to adjust our analysis to account for this adaptation. And so we looked at outcomes after the initial program implementation and then after the adapted implementation. So what this program is that a patient who is deemed at high risk for readmission, and we calculated that using an internally developed readmission risk score, which I'm happy to provide more details on it if for anyone who's interested. But we looked at patients who were at high risk, and then they were offered this program. And the program consisted of, at the beginning, before the adaptation, either an advanced practice registered nurse or a paramedic going to the patient's home to do home visits for 3 visits for the month post-discharge. And what happened after the adaptation occurred 5 months into the program is that we realized that it was better to have teams of paramedics and advanced practice nurses and not one or the other going out to patient homes, and then that the visit number increased from 3 to 4. So again, we had to examine our data based on when this adaptation had occurred. So again, what we found, and this is I'm presenting just one slide on the quantitative data so that we can have lots of time for discussion. But during this adapted program period, we matched 197 discharges who did participate in the home visit program with those who didn't. And for those who declined the program, we actually took them out of the control groups. Anybody who was offered and declined is not in those who didn't participate. And we matched them on several criteria that you can see. And what we really found is that the patients who participated in this post-discharge home visit program had fewer readmissions in 30 days, but there was no effect on the readmissions in 90 days or 180 days, or on emergency room, emergency department visits, or on mortality. But we did see this effect, and our data source here was the electronic medical record. So we delved a little bit to try to understand the variation because we really are interested in context, and we looked at our 9 hospitals where this program was offered. And what we found is that there was a significant variation, like even looking at hospital 6 and hospital 7, looking at the number of patients who accepted the program and those who declined, and that there's a significant difference in these 2 hospitals. So what was going on in these hospitals where a lot more patients were accepting at one and declining at the other. So again, that just opened up this interest in understanding context a lot better. So in terms of our qualitative data collection for this project, our data sources were really just in interviews. We did not do observations here. So we had 22 patients, and then nurse care coordinators, primary care providers, paramedics, and advanced practice nurses who all went through an audio recorded interview with our research team. And what really came out of this is that understanding of medications was just such a common theme, that patients would go home and not understand what their medications were for, wouldn't understand medication changes, well, especially if there were change from what their primary doctor had been prescribing to them for years, they were a little bit hesitant to go on to taking a new medication that was prescribed in the hospital. So there was a lot of confusion about medications. And we also found a significant gap in just kind of overall understanding of the health condition, issues with health literacy, the need for patient education and guidance. As you can imagine, we were looking at a group of patients who were deemed to be at high risk for readmission. So there was a lot of patient complexity that could be affecting what we're seeing with our readmission percentages, and a lot of concern about financial barriers, even to obtaining medications, the lack of social support for a lot of patients, and just this need for patient engagement and reassurance after discharge. So a lot of times, and we have several quotes that, in the interest of time, I won't share it right now, but there was a lot of interest in patients just accepting this program because they thought, oh, well, I can, there will be earlier identification of a change in my status. And there's just this need to be engaged with the healthcare system post-discharge. So in terms of how this can inform future interventions, just our uncovering of our medication understanding problem has led to a lot of other initiatives that have been offered. And I will tell you that this project that we did was of significant interest for our operational leaders, because just uncovering and really thinking about context and other issues that maybe wasn't as clear just from our quantitative data has led to a lot of interest in kind of thinking about where we should focus future efforts. So again, just a second example of how we might use mixed methods to really rigorously study practice change. So I am going to stop here and open it up, and hopefully several on the call maybe have had similar experiences of studies or may have some questions for us in terms of what they're doing or what you're trying to do in your own practice settings. So thank you. Any questions?
I don't see any questions in the chat, so perhaps maybe we can move forward if you like.
Question.
Okay.
How do you figure out how many people you have to interview for qualitative work?
Yeah. Yeah, that's a good question. Well, qualitative doesn't have to be like, there isn't really this concept of having like a representative sample statistically speaking. So like if you have a population of this size, you need to have this size number of interviews. So, so I would say that for any particular site that you would be doing, like trying to do some qualitative work in, that it could be, depending on the type of intervention you're studying, it could be as little as 5 or 6, or maybe as many as 15 to 20. I mean, 20 for a qualitative sample is pretty large, really. And one of the things you want to keep in mind when you're doing qualitative is that you may have a set of questions that you're starting with, and you may want to think about the types of people you want to speak with even more than how many. So do you want to speak with the clinicians and the patients and the vendors, or, and then within each group of people, like what's a reasonable amount you can interview in a certain amount of time, like who's doing the interviews. You have to kind of balance your resources with your time, but you want to interview enough people where you start to hear similar things over and over again. We call it like saturation. So if you've reached that point, that's generally a pretty good estimate of like how many people you need to speak with. So, I think for me, it's good to try to reach around 10 and then sort of reassess, like, do we think we need to talk to more people? Do we not need to talk to more people? But there at no point would you then interpret the data as being representative of the larger population. It's still essentially just your sample, and you don't necessarily generalize from it based on that. But it could help you make decisions like, do you need to talk to other people? Do you need to talk to more of the same people because you still don't really understand like what's going on with this complex thing you're trying to understand? Is that helpful?
Sorry, I couldn't unmute. Yes, that's very helpful. Thank you.
Okay, no problem.
Okay, we have a question in the chat.
Yeah.
Thank you, Heather, for your question. Are there any specific approaches you recommend to decide which stakeholders to engage in qualitative research?
Well, if you're doing this for like evaluation purposes, you generally want to think about who was involved in the intervention, and that's who you mostly want to engage in the qualitative interviews. So if the people involved in the intervention were the clinicians and the administrators and the technicians, let's say, as well as the patients, then you might want some from each of those categories. If you're doing like a community-based intervention, then you also want to think about it in terms of like sectors. So there might be the immediate people who were running the program and being affected by the program, but how does it fit into the larger community, and what are other contextual issues that you want to try to understand as far as this program? Then you'll want to think about that community. So it could be maybe faith-based, or people in government, or people, funders that are involved in this kind of system that this program is taking place in. And generally, you want to think about like all the types of people that are kind of central to making the intervention work and not work. And then again, you go back to this kind of like, well, what's a reasonable number of those people I could speak with to start to get a sense of the questions I have, and then you can decide if you want to speak with more. But it's all, I think, pretty particular to the project you're evaluating. If that's
I would love to add to that too,
yeah.
Dr. Freij, because that everything you said, absolutely, anyone who would be potentially involved in that particular intervention, but then just whenever you're implementing something and you're asking someone to take time away from something else to do the thing that you're implementing, I always feel like you need to think about that group too. Like, who else will be affected by this that isn't directly maybe involved in what you're trying to implement? Because usually if they're involved, they've somehow decided that, yes, maybe it's probably worth it to do this. But then there are people who sometimes are affected by what's going on. Is this care delivery change taking away from something that I think is really important to what my priorities are for my patient? Because every time you implement potentially an alert in the electronic medical record, it takes attention away from a different alert that was there before. And so I do think just being aware of who can be affected by your effort, in addition to those who are directly involved with it, is something that I feel like I've learned to include in groups that we want to talk to.
Yeah, and I don't know if this is putting it a different way, but you reminded me of something. Sometimes we interview non-participants, like people who weren't engaged, and that is another population, like people who didn't buy in or who didn't participate, because you want to know why.
Right.
what was the reason? And so
Right.
I'm not sure if that's putting the same idea put differently, but you reminded me of that too. That can be another important stakeholder.
Okay,
Absolutely.
we have another question in the chat, and this is from Tiffany. A comment: "This was wonderful. Thank you." And she has two questions. The first one is, are core components just decided by researchers upfront and reassessed over time? And the second question is, do you have to disclose adaptable periphery pieces when publishing?
I could start with that,
Sure.
just and then leave plenty of time for you, Dr. Freij. So I think that the implementation piece, I mean, I do think, yes, researchers or the evaluators are involved, but it's really, I think, the operational implementation of a model or a new care delivery model or a new tool, where it's almost like the researchers in conversation with the operational staff who are actually implementing this new model need to decide what really defines that model. And I think as the evaluator, I always take a step back as a researcher evaluator to say, well, I need to know from the operational standpoint what you really think is important for what you're implementing, and then we'll evaluate it. And then the adaptable periphery, I think, is something in terms of publishing, as I see the second question is just, I think you do have to clarify if something was adapted. For example, the study I just talked about, there was a major adaptation in the middle of this implementation. And I think that we definitely have to acknowledge that in the publication, if as a researcher. But go ahead.
Yeah, I agree with both of your statements. In terms of the core components, sometimes we're, as research, a bit theoretically driven. Like, for example, Dr. Misra-Hebert pointed out the CFR framework. And in some ways, that framework primes us to what we want to look for and like structure our research questions. But it's very important to clear that with the people you're like actually researching. Like, does this framework make sense? Do you have any of your own questions? And so forth. I think even more importantly, though, if you're engaging patients or community members, understanding what they want to see change and what are their outcomes of interest and what process questions they may have, I think is really important. And it gets to that equitable and culturally responsive evaluation that is something we all strive to be those kinds of researcher. So ideally it's collaborative process for just, identifying the components. And I'll defer to Dr. Misra-Hebert's comment about the adaptable parts. I know that comes up a lot in clinical trials and things too. If like you get along and you have these arms and one of them changes, like, what do you do? So
our next question is from Ting. Any suggestion of how to implement results from a QI project?
Meaning like you've identified an outcome of that was good, and then you want to like implement them other places, or I mean, maybe Dr. Misra-Hebert understands. I'm not sure I understand that question.
Yeah, I was actually going to ask for clarification as well, but it was but I'm thinking like you implemented something that worked, and was there a particular strategy that you identified that worked for that QI project? I mean, in many ways, the same principles apply for a QI project and kind of scale up, maybe if that's what Dr. Freij was referring to, and what maybe you're asking is what were the components that really worked, which strategies worked, and then do you want to test that strategy that you used in the QI project with another one? And that would be potentially an implementation study that you could do. Right,
I know. I had a similar thought that like I hate to recommend taking results from one study and just doing another study, but there is that whole field of like scaling. So you've identified something and then you want to try it elsewhere. So the implementation study itself, if you know the outcome, can help you, I think, with that replication. So like what worked, what didn't work, and some of that qualitative implementation data, I think, can help with the implementation in other places or scaling maybe to other participants even in the same setting. but if you have other questions, I know we're at time, but we're really, I'm very happy with all these questions.
Okay, let me see. Tiffany has a comment. She
Mhm.
said, very helpful, thank you. It's tough evaluating programs that may be altered over time based on participant feedback and by those external and internal factories / setting. Let's see. And another question from Heather. Are there certain approaches with quantitative and qualitative data assessment that are best for populations that have a lot of social determinants of health factors? And she says, for example, if there are lots of patients with SDOH barriers, is it better to look at a percentage of patients that achieve improvement or percentage of patients that achieve a certain score?
That's a very good question. One I think many of us are struggling with actually at the moment. I don't know if I know the right answer, but it is something that to consider. I don't know if Dr. Misra-Hebert has a good response to that one, but I did put my email and I want to thank everyone and I can think about it some more.
She responded with example on a diabetes study. Is it better to look at 1 point improvement in A1C versus percentage that have A1C below 7?
No, I think that is very interesting. And as you know, quality metrics are based on a certain number below a certain A1C level, but we always actually, in any diabetes studies we've been involved with, we've looked at both. And I do appreciate that question. And I think it's, again, for that type of study where you're trying to maybe understand, are there other factors contributing to that lack of decline in A1C? That's where some of the qualitative work may be incredibly helpful to try to understand why in this practice you're seeing very minimal, or you don't get to the goal, but you are seeing a change. And maybe there are some other barriers you could address to effect a more significant clinical change. So yeah, that's a great question.
And I think that is it for the questions.
So I know we are a bit over time, but thank you all so much for taking the time to join this presentation to hear Dr. Mason French and Dr. Nita Misra-Hebert. If you all have any questions, please, you can follow up with them. They have dropped their email in the chat box. And please don't forget to fill out the evaluation link. Thank you all so much, and we hope to see you all next month for our next learning series. Bye-bye.
Thank you.